Okay, so next we are going to have a panel discussion on the personal and societal impacts of non-eco-friendly dialysis. We have two speakers for this panel. Unfortunately, this is the panel that Henning was going to join us for, so we will honor him during that period. But first up, we have Mohamed Hmida from Tunisia, who will speak for about 10 minutes on what he's experienced as a nephrologist in Tunisia. And then we'll have Junelle Speller, who is a healthcare consultant, policy expert, who also has a history of kidney disease, has lived with dialysis as well as transplant, and we'll talk about her personal experience living with many of these non-sustainable aspects of dialysis. So first up, Dr. Hmida, if you'll speak.
Thank you very much for the kind invitation. Just to add that the presentation will talk about from crisis to opportunity. And I kindly request 2 additive minutes. Non-eco-friendly dialysis isn't just a challenge for the healthcare system. It carries personal and societal ramifications that ripple far beyond the treatment room. Below, and at the end, we'll see some case reality experiences and became more and more burning topics. We'll start with the key personal implication on staff, provider, emotional, and mental stress. Heat waves exacerbate known and undiagnosed CKD, leading to end-stage kidney late referral, and announcing the kidney replacement therapy starting can be very stressful for both the patient and the renal care staff. The frequent occurrence of such presentation lead to a burnout syndrome in young residents with specialty change requests and in young nurses with unit change requests. Knowing that working on a life-saving treatment contributes to a broader environmental degradation and can add the emotional burden faced by renal care staff, compounding the psychological stress of managing a chronic condition. In addition, it is an opportunity to deconstruct the cliché that are the main barrier to early mental access to kidney replacement therapy, and thus have the possibility of living an ordinary life for both patient and renal care staff. What about the couple journey in dialysis? Fortunately, the wife donates a kidney to save her husband, and vice versa, thanks to God. But sometimes the settings may lead to divorce, homelessness, and even dialysis withdrawal. And as you know, wives are the most vulnerable. What are the impacts on overall quality of care? Facilities that do not invest in sustainable, eco-friendly technology may also have outdated practices or equipment, which might correlate with less optimal care outcomes. Improved eco-friendly systems often incorporate newer, more efficient technology that can enhance both treatment quality and safety. What are the impact and direct health effects through environmental impact? Although non-green dialysis does not directly impair the clinical effectiveness of the treatment, the broader environmental degradation, such as pollution or strained local resources, can indirectly affect community health care and consequently their well-being. The indirect health effects through environmental impact. As widely reported, 2023 and 2024 were the hottest years, and the past decade has been the warmest 10 years. Years of warming and drought succession have led to significant drop in dye quarter levels, the worst of which occurred in 2023. The situation had led to drastic reduction or even a cessation of the drinking water supply to the entire region, my region's FACS. What are the alternatives? This critical situation for hemodialysis center has justified the help of tanker and tractor to supply water from groundwater wells at a high prices via a regulated market, opening unexpected growth of an illegal water market. The additional cost incurred by the hospital and dialysis facility is substantial due to the enormous daily water quantity required. Besides the financial burden, this water scarcity implicitly reduces the length and the number of dialysis sessions per patient. What are the impact does water scarcity have on provision access to dialysis? Water stress and aridity contribute to the dialysis equity burden, and water scarcity in arid region like mine necessitate an innovative approach to sustainable management. In many traditional setups, a significant portion of water is discarded rather than recycled or repurposed, contributing to water scarcity concerns a region where water is limited. We move now to the waste impact. Hemodialysis waste management has sometimes suffered from poor governance or non-governance with uncontrolled burial or incineration exposing to environmental to potential infectious and pollution risks. To help solve and govern this problem, a logistic approach was settled with each financial burden allotted. How the operational and waste management costs implication dialysis provision. Disposable material. Many dialysis setups rely on a single-use items such as dialyzer tubing and plastic packaging. This leads to a large volume and amount of plastic waste. What about disposal cost challenges? Medical waste must be handled carefully, often incinerated or sent to landfills. Incineration can release harmful pollutants, while landfill disposal can contribute to long-term environment contamination. What about ethical and equity consideration? Equity and access about resource allocation. A region with limited resources, the high environmental and financial costs of non-eco-friendly dialysis can exacerbate healthcare disparities. This may result in unequal access to a life-saving treatment, especially in low-income or resource-poor settings. Balancing immediate need with long-term sustainability poses ethical dilemma. While dialysis is essential for patient survival, its environmental toll raises questions about long-term societal impact. The challenge is to balance the need of life-saving intervention with the responsibility to protect environmental and public health. The ethical and equity consideration in regions with limited resources the high environmental and financial cost of non-ecological dialysis can exacerbate healthcare disparity. This may result in unequal access to life-saving treatment, especially in low-income resources. I move now to heart-touching slides, and this dedicated to our loving friends. And I had slides about death, and we have to share and break the taboo of the impact of death on caregivers. You know that word in this slide carries emotional weight. People may not remember what you said, but they'll certainly remember how you treated them. We intervened our own deaths as a caregiver with those of our loved ones, our transgeneration deaths, and those of our family history. Our coming out is our vicarious trauma related to death of our patient. It developed over the years by taking close care of our patient. With each patient, where death manifests itself, we can see the distress of other patients and families. And this brutal realization that medicine cannot make you immortal, that caregivers have limits, and that is when emotion arise uncontrollably, that violence can appear on both sides. With the driving element, the feeling and the emotion are from the tolerable to the intolerable, and from what we can hear to what we cannot hear. The problem is to be a savior, but to not or to forget ourselves. Bravo, and thanks to all the silent caregivers. Just to conclude, I leave you this appreciation and how we can move with this quiz reality to quiz reality. How to move from depression and hemodialysis patients to such activity and to lead to several publications. Physical activity during dialysis and several papers about that. And now, an excellent case about nocturnal hemodialysis that led to healing by night, to truly live by day, or to restoring health at night, to reclaim life by day. The virtuous cycle of nocturnal dialysis is exposed through the parallel of the unique training required for an ultra-trail race. Fabrice Houré, who undergoes long nocturnal dialysis, doesn't let kidney failure stop him from participating in numerous supporting events. He's taken an extraordinary challenge, especially remarkable for someone undergoing dialysis, by signing for the legendary Diagonale des Fous at La Réunion, on La Réunion Island. The virtuous cycle of long, no. Absolutely. The wording in the slide doesn't have strong uplifting tone. It emphasizes the resilience and determination in the face of adversity, which can inspire and motivate audience. Highlighting Fabrice's perseverance, despite undergoing nocturnal dialysis, transforms a personal challenge into a powerful message of strength. I end with some dedication to all my mentors in Europe, Professor Claude Jacob, Megid Nahas, Pierre Ronco, and this person. The wording in this slide carry empowerment and motivation weight. Réussir, c'est travailler et lire pour s'émanciper et s'épanouir. You understand what I mean? And I will end to dedicate to the soul of my late parents, who taught me since how to transform everyday scarcity and everyday difficulty into an opportunity, and you can succeed. Yes, we can. Thank you very much. Sorry for the few minutes I take.
He did very well. So thank you, Dr. Hmida, for leaving us with that extra word of motivation. So I'm going to ask Junelle Speller to come up and speak about her experience, and then we'll take some questions after she speaks.
First of all, I'm really thankful, grateful, and honored to be here today. Mohamed, I have some mixed feelings about doing cycling while dialysis. I must say, I was very exhausted at the end of the day, and that was furthest from my mind. So, but you know, great idea nonetheless. So I was a PD patient, and I was 32, 33, when I was diagnosed initially with CKD, moved on to ESRD, and then my diagnosis of FSGS, focal segmental glomerulosclerosis, was confirmed. At the time, I had 3 kids, a husband who's over there taking pictures, And I was active professional. I just started my career maybe 8-10 years before, and I was climbing the ladder. So when presented with the options for PD versus hemo, I chose PD. And you see this big icon here. No needles was my initial reason, but moreover, it was really about maintaining my level of independence, empowerment, being gentler to my body. I was young. I had presumably many years ahead of me, reduced vascular stress, preserving my kidney function. I was still urinating, making urine at the time, being able to drink more, and when I did have to go on hemo, I understood why that was so important to me. And the ability to travel. I actually did PD while doing management consulting for a year. So I was on a plane with my PD machine. I had my solution sent to the site, and I was on the road doing PD. Not advisable, but I did it nonetheless. And then the last point is that it's greener. For me, using less electricity, producing less water was really important. So this is my prescription, and I am a transplant patient. Let me just say that. I'm no longer on PD. I got my second transplant at NYU. Morgan Graham, thank you to you and your team. I'm originally from Chicago, so my second transplant was in 2022. I did PD for 8.5 years in total. Round 1 was in 2009 for 6 months. You see my prescription here. And then round 2, I put it in months just to make it resonate. It was 97 months of PD at the highest 9 hours overnight. I had that overnight transformation. I was being healed at night, and then I was able to resume my regular activities during the day. But you see the consumption of solution that I had here, 6 exchanges, 3 bags in total, plus a midday exchange. All of these supplies total, the cassette, the mini caps, the flexi caps, and so forth. So the boxes, we're all familiar with the boxes. The boxes, priming, connecting, during the process, and then afterwards the waste, the insurmountable waste, and the boxes as well. Now, this is not a picture of my house. We did not do this. We actually flattened boxes, but by the time we flattened boxes and brought them to the curb, no one really wanted to take pictures at this point. So I took this shot from the internet. So my daily treatments produced up to 2.2 kilograms. I asked my chief waste officer over there in the corner about how much the weight was on average. It was about 5 pounds for us, or 2.2 kilograms, as well as the excess electricity, which really exponentially increased my household's carbon footprint. The 9 hours, I did my own quick math. It was about 396 kilograms of CO2 emissions per month from plastic waste alone, and then about 13 kilograms of CO2 emissions for electricity use. Combined, that translated to about 1,600 kilometers, roughly equivalent to the emissions generated by driving round trip from Berlin to Brussels in an average gas-powered automobile. So it's pretty significant. And I used some of your, back to here, I used some of your references to make my calculations, so just wanted to do a plug there. You're welcome. So there was a tremendous impact for us, certainly the physical impact of handling and disposing of all of that waste. My husband, my 3 daughters at the time, I had 2 toddlers and a preschooler when we started this process. They're now 18, 19, and 23. We collectively spent over 2 hours each week disassembling boxes, discarding used dialysate bags, drain bags, supplies, and packaging. And I'm saying all of this because it was a lot. When we did flatten the boxes, there was no guarantee that it would be recycled. And then it got to be so much at the point like year 5, 6, 7 that we needed additional bins from the city for a total of 4 bins, 2 recycling, 2 trash for weekly garbage pickup. And then the emotional impact. Certainly, as the years of PD drones on, I increased stigma due to the conspicuous waste. It signaled a medical issue to my neighbors. We had moved around a lot, and the Baxter truck is one thing, every month, but every week, 4 bins overflowing, Baxter boxes, tubes hanging out, and so forth. People knew something was going on at my house. And then the embarrassment, the excess waste every week, and then really feeling guilty about the plastic waste that was being produced. Notwithstanding the amount of dialysis I used, there was also damaged dialysate bags each month. So that added further to the waste. And then even after transplant, when I was hoping to return my unused bags and supplies, my transplant center said no. So despite these challenges, there was a bright side. We stumbled upon an unexpected benefit. We initially would put the effluent in the drain bags. Trash collectors were mad. They weren't always disposed of correctly, and there was a lot of spillage, which was not cool. But then the second thing we did is we would put the drain line into the toilet, and that was really costly for us. It used to cause clogging with the fibrin and other particles in the effluent, so plumbing issues in our old historic home. So what we did in the warmer months is we would drain the bags outside in our backyard in the plant beds. And the result, beautiful garden. Our tomatoes, this was the end of the harvest season, November, and we had bountiful harvest here. This was my control group. This was pre-effluent. You see that little puny cucumber? And then post, my dad holding just a fraction of what was produced from that unbelievable discovery. So that was a plus side. So key considerations, I think, in the process of learning all of this, it was mentioned before, it is really harsh. It's a lot to take in for a patient, caregiver, and family that you have to go on PD. But I think in the process, at least in the initial months, to really talk about the environmental impacts, right, and advise on local disposal options. Recycling is important too. If there's a recycling protocol or program in the dialysis center, that would be important. And then I took the lovely kidney disease quality of life survey constantly. I think it would be important to integrate environmental questions into that as well to see what the impacts are on patients. And then, we have some manufacturers here advocating for greener packaging and recyclable components would be really important. Really looking at how to mitigate the environmental factors, because a lot of patients are thinking about this. It's already a burden for us on our families, on our workplace, but also to leave that on the environment, it's just a lot while managing disease. So I'm glad to be here. I'm glad we're having this discussion, and thank you very much.
Thank you. That was fabulous. Is this working? Excellent. So it really brought home, I think, what actually happens in the home. And I guess my first question will be to Junelle, and then I would welcome all of you to raise your hand if you have questions. And I'm just curious how prepared you felt for this. When I'm telling my patients about what peritoneal dialysis might be, I usually tell them about the boxes, but that's where my advice stops because I don't live the experience in the home. How did you, were you prepared, and what could have we done differently as you were preparing to do dialysis?
Hello? Okay. So I was not prepared at all. I knew the boxes would be a huge factor. We had, a place in our home set up to do that. We had a system where my husband would bring up the boxes from the area that we had on the ground floor. But the waste, not at all. Not at all. The plastics and the breakdown and just, the impact to all of us to see the, sometimes it seemed immeasurable amount of waste that was produced in the process. So no.
Dr. Hmida, question for you. So one of the things that you talked about was the impact of water scarcity with the shortened treatments and the fewer treatments. And I'm just curious, in your own practice, number one, how many patients do you take care of? And then what actually happened with their treatments? Did you go to 2 treatments a week? What was the actual patient level impact of some of the water scarcity?
Yeah. We tried several ways to face this situation. Per year, we have up to 12 to 13,000 sessions per year in our center, with a huge amount of water, 6,500 cubic meter per year. So with water scarcity, we have to level and to balance our situation. We settled incremental dialysis. And you know, with incremental dialysis, for every month, incremental dialysis, we can save 4 sessions. 4 sessions, it does mean 2,000 liters per month for every patient, month. And we have tried another solution, the delay of starting dialysis. It is not taken for granted to put all patients under the same rule. 10 milliliter of GFR, start dialysis. No. Every patient is a different case, special case. When patient has residual kidney function up to 5 milliliter, we should keep this residual kidney function. Is the security super for everything, for pulmonary edema, for everything. So starting with dialysis 3 sessions per week, you will kill this residual kidney function.
No,
By using this, we save the kidney function, and we save for every month delay, 12 to 13 sessions, that's multiplied by half cubic meter, 6 to 7 cubic meter a month patient. So,
Yeah, and that's a great setup to group 1. Incremental dialysis is something that they'll talk about as a strategy for lowering water use. I'm going to take a couple questions for the audience. Thank you for that. Edwina.
Yeah, I'm going to ask about does the water shortage change people's minds about using PD a bit more? PD is underutilized in Tunisia. If there's not enough water to provide sufficient hemodialysis sessions, does that change the mindset that PD may be preferable?
Yeah. Because before answering, does anyone in the room can answer that PD use less water than hemodialysis? No, because we don't know what happened in industry. We
Yes,
don't know
but
the
we're
amount
talking
of water used to prepare 2 liters of PD dialysis. And I asked several manufacturers. In UK, back there, and so on, I have no answer for 3. Several mails were sent, and I have no answer.
Yeah, but PD fluid may be being made in areas of the world where there's more water. In Tunisia, the problem is that there's not enough, and I've just been in Morocco, where equally there's been a drought for many years and huge water shortages. There's not enough local water for hemodialysis. So therefore, putting more people onto PD may save the use of local water in hemodialysis.
May I add that the footprint to import PD from abroad should be added to the impact, the environment impact of PD. I'm not against PD. We have, and we should have balance, what we need and what we do.
Well, and these are the exact issues we'll wrestle with, because there's the immediate local impact, but to your point, when we're shipping it in, what we saw from the first presentation, that has its own carbon footprint as well. So point well taken. Georgie.
I just wanted to thank you for raising the issue of a huge quantity of garbage, because it's not just a question of being, let's say, looked like a demon by your neighbors. Is also, for example, in Italy, in some regions, there is a law for which you cannot throw away your filters if you are on home hemodialysis, and in some places even PD. So you have to gather it, and there is a service coming and picking it up, which is not so bad because you can learn how to minimize the quantity of garbage, etc. But in front of your house, there is twice a month at least a car that comes with potentially dangerous hospital waste. So what about privacy? So this is, I think, your point is very important and is something that we physicians have to think about, because we sometimes focus on efficiency, data, but not focus on small things that may have a very bad impact on your life, like living in a crowded place and you have it means that you are potentially contagious. So it's one of the things we have to think about. And once again, what's good for the patient is good for the planet.
That is really important, the lack of privacy. And in the US in particular, I live in Chicago, my transplant was in New York. There is a lot of stigma and miseducation about kidney failure. So then not only was I the patient doing PD at home and dealing with all of that, then I had to get ahead of it and tell my neighbors, you know what, I have kidney failure and this is why. No, I didn't drink a lot. No, I didn't eat poorly. This is why. So I had to educate people because that waste signaled that something was going on at our household. So it was a lot.
Jeff.
Thank you. A couple points. One, I really love those tomatoes, and with more liberal potassium intake, you can enjoy them too on PD. But just one overarching comment about the conference that I just thought about as the plenary happened is that we are experiencing now the impact of the environment and climate change on dialysis delivery, with natural disasters and dialysis disruption and a recent solution shortage in the United States that was a direct response to climate change, I think. So I think that the time is now more than ever to have this conference, and I think we need to just put that in the context of dialysis is being disrupted today and will continue to get worse over time if we don't make these changes. But my question to you, Junelle, thank you for sharing your personal experience about it. Do you think that, there's a huge global difference in the use of CAPD and APD, with the US actually being a very heavy user of APD. And I never thought about the stigma of garbage and, the amount of waste that it generates and sort of impact on how neighbors perceive that and whatnot. Do you think that we're educating on CAPD enough? And do you think that's something that you would have thought about differently, doing manual exchanges over APD because of less consumable generation?
Just for the first question, no, there's not enough education. It's more about getting started, the clinical aspects, the medical aspects, your electrolytes and so forth, your KT over V, et cetera. I would not have gone to CAPD. I think for me, disconnecting, reconnecting, disconnecting, I was concerned about the exposure to infection and the increased chance of peritonitis. So I wanted to reduce that to the extent that I could. So being able to sleep while doing it, and having to adjust my sleep position and the noises, we got through that, but that was more important to me, just, as far as integrating that into my overall life.
Charles.
Just a comment about Mohamed Ben Hmida remark about consumption of water between PD and hemodialysis. I have recently reviewed a study for about life cycle assessment comparison between hemodialysis and PD and transplantation. And I was very surprised, but the consumption of water was equal between PD and hemodialysis. And life cycle assessment is much broader than the carbon footprint evaluation. So it may be, of course, I have questioned the authors to comment more about this on their paper, but I have not the answer yet, but it was they found.
I think it is a single modelization to compare PD to hemo, because there is no data. How do they compare? Where they take the data?
Yeah.
Industry refuse to give data about PD generation and the PD amount of water used.
Yeah, we know from John Agar that we need 180 liters of water for 1 kilo of plastic. Yeah. So to make 1 kilo of plastic.
I calculate all the amount, but the problem the amount of water used in industry to prepare the ultra-pure water for the single bag of PD. What is? I don't know.
Thank you.
The point about the life cycle assessments is very important, and I think it's something that we should keep in mind as we have these discussions the entire time. To the front.
Yes, I can come back to all this enormous amount of waste that is generated, and 99% of all healthcare waste go to landfill mass or incineration. But there are actually new opportunities here that I think we should discuss at this meeting. There are new technological ways you can actually autoclave plastics from patients with like big microwave ovens that don't destroy the polymers, and this plastic can then be used as construction material and recycled. And another opportunity would be to use 3D printing locally, to use the plastics, and you can generate the plastic material for healthcare. So there are a lot of opportunities here, and I hope really we have the opportunity to discuss this during this meeting.
Your proposal is welcome. I'll bring in tomorrow.
Yeah.
Yeah, for all Tunisia, I promise.
Suzanne.
Thanks. Question for Junelle. So there was just an article on Thursday in the New England Journal talking specifically about a research agenda for action in climate change, which is actually pretty impressive. And one of the 4 areas is specifically about engagement and public awareness. I'm just wondering, there are a lot of PD patient groups that do meet, that share practices and help to educate the community, inform policies, for example. Is this one of the areas that you talk about or that gets publicized amongst patient groups that you're aware of? I'm just kind of curious.
I was part of PD patient groups on Facebook through 2020, and then I just had my Facebook moment and had to scrap it all together. But it was very helpful in terms of, how to do PD, management of lifestyle, diet, and so forth. There wasn't a lot of discussion about the waste, right? There was about the box storage, but not, at least in the forums that I was in, I was about 3 or 4. But there wasn't a lot of discussion about the waste, and that may be something that people deal with privately, like my family and I did, but I didn't see that broadcast, everywhere. I think it would be important to raise it to the level, so that patients know that we're thinking about this and what are the methods to help patients and families deal with that.
Okay, I think we have time for one more question, please.
So I like the discussion about the role of industry. And I want to stimulate some thinking about setting standards for both the environmental impact, the carbon footprint of the product, and recycling. And when the societies, so the nephrology societies, are going to set those standards, the role of competition, which is the most impactful thing for the industry, competition between each other, can get more standardized. So in that stage today, so they are afraid of being in a worse position against their competitors. But if there are standards, so this gets much better, and therefore I want to stimulate our role to ask for those standards, monitoring and recycling, to make things easier even for the industry.
Thank you for that. Morgan, did you want to say something?
I don't mean to prolong the discussion. I just wanted to thank Ms. Speller. That was so enlightening, and thank you for bringing your personal story. I think it's something that we don't think about at all, so I really, really appreciate it.
Yeah, I agree. Oh, Boko has the last word.
As for standards, I might be able to help. If KDIGO from this conference would formulate a request to the standardization committees, because I'm part of the IEC, International Standardization Committee on HD and PD. If I get a formal request from a KDIGO meeting, I can bring it into the meeting of the IEC and maybe even ISO and say, well, I got this request. We have to do something.
No, thank you very much. And that's really the point of doing a conference like this, is it gives us, it really gives us that foundation of knowledge and clear push from the community. So thank you. So thank you, everyone. We are going to take a break now for, I believe, about 10 minutes, and we'll come back, and we'll continue with our plenary.
That was a good stretch.